So we know that for chronic limb ischemia, we have two options of management. One is medical and surgical. In surgical, again, you have two options. One is the endovascular treatment, and the other one is the open bypass surgery. In this video will precisely discuss about endovascular treatment. In endovascular treatment, which patient will benefit? So primarily, it was reserved for proximal lesions and short segment lesions. But now with the advancement in technologies, distal vessels like tibial and pedal vessels are also being addressed. And second thing is, it is usually reserved for patients in whom the life expectancy is not that great. So shorter life expectancy, it is no point in subjecting the patient to a morbid procedure like a bypass procedure. In such patients, you can plan for a endovascular management. And short segment lesions, see, if there are multiple lesions, it is obviously difficult to do a EVT for that patient. So multiple levels, so in the and a long segment, especially greater than 4 centimeters, it is better to go for a open surgery. And yeah, other classification that we need to remember is the task 2 classification. In task 2, the D type, task D, obviously it is a multi-level disease where endovascular management is not feasible. In such cases, a open bypass procedure is done. And if the patient is having serious comorbidities like coronary artery disease and COPD, in such patients, it is better to go for endovascular management where it can be done under local anesthesia with mild sedation. So these are the situations where a endovascular management is done. So concept is you have a disease vessel with a atheroma or plaque. So idea is you have to pass a guide wire beyond the atheroma and guide wire, beyond the atheroma or the plaque. And once you are into the true lumen of the vessel beyond the lesion, you have two options. You have three options available. One is angioplasty with a balloon, and then other option is to put a stent, or you can do a atherectomy. So these are the options available. So different situations demand different management. So thing is, the most common entry point is from the common femoral artery. So again, a most common complication during the endovascular treatment occurs at the site of the axis. So these are very important thing. And the axis either can be a retrograde axis or the antegrade axis. So once you have planned for the management, now you pass a guide wire. Once the guide wire is passed, the size of the guide wire, again choice is 0.035 inch guide wire for larger vessels like the common iliac and the aorta, and for smaller vessels like tibial artery and renal artery, you and the carotid artery, we choose a smaller diameter guide wire like the 0.014 inch to 0.018 inch guide wire. So yes, so now we have passed the lesion. What we need to do is we plan for a uh, stenting or angioplasty or atherectomy. There are certain situations where you are not able to pass the guide wire beyond the atheroma or the plaque. So here you have two options. One is a novel concept called subintimal angioplasty. You deliberately pass the guide wire, which is a J-tipped guide wire, through the subintimal space, and then do a re-entry. After you pass the plaque, you will try for a re-entry. Sometimes the re-entry may not be possible. Then again, you have a device called a re-entry device, which will facilitate the guide wire to come back into the true lumen. Once it is in the true lumen, again you can go for either angioplasty, ballooning, stenting, whatever it is, or removal. So that is how you can negotiate a hard, difficult plaque. So other techniques that can be used for bypassing the difficult plaque are, you can have a plaque micro dissection, or a bidirectional catheter spinning can be done, or there are certain devices which facilitate advancement with catheter tip deflection capabilities are there, with which you can facilitate the advancement beyond the difficult area. So again, once now you are inside the true lumen, what you can do is you can open up the lesion by doing a ballooning PTCA, like the PTCA. So what you need to do here is the size of the balloon. For that you do a intravascular ultrasound and determine the size of the balloon, and based on that you inflate the balloon. So this is what happens. And again, there are balloons, drug coated balloons are there, like what they use in the coronary vessels. But the drug coating balloons, they have their own demerits, because the multiple studies have noted that the mortality rates are more when compared to coronary vessel ballooning. And again, mm, angioplasty is actually reserved again for proximal arteries and again shorter lesions. But now, as I said, with advancements, pedal arteries and tibial arteries, they are also being dealt. So when to use a stent? Stent is usually reserved when there is some complication after angioplasty, like there is any dissection in the vessel, or there is any restenosis, or to address some other complications, you use a stent. Again, stents are there. You have the covered stents, bare stents, all these things like the cardiology. You have all these stents which are there are self-expandable stents, there are balloon expandable stents. So important point worthy of mention here is a study has found that stenting is superior to angioplasty in iliac vessel lesions. So this is a very important. So question can be asked whenever you are looking for endovascular treatment. If they find something called iliac vessels, then stenting scores better than angioplasty. And the last option that is available is atherectomy. So atherectomy is done with a laser, but the main advantage of atherectomy is whenever you are encountering a difficult lesion, it will help in debulking the lesion. Thereby, it will facilitate your guide wire or your deployment of a device would be much easier when compared to having a large atheroma in situ. So this is about the different techniques of endovascular management. So ultimately, which choice to be done depends on the grading of the chronic limb ischemia. So when the patient comes to us, what we need to do is we should initially evaluate and assign a score called the SVS Wi-Fi score, and then you have to identify the target arterial path. Before that, you do something called plan, where you assess the status of the patient, his status of the limb, and then you give a grading called glass grading. Based on all these factors, a certain modality of treatment, either endovascular management or open bypass surgery, is planned. So ultimately, endovascular management, to conclude, is reserved in patients who are having the short expectancy, is more useful in proximal lesions, is more useful in short segmented lesions, is what to say, mm, not that of great use in patients who are having a poor distal runoff, and care should be taken in patients especially with diabetes and CKD patients. So this is about endovascular treatment. Couple of studies that we need to remember here are the best CLI study and the basal study, like the basal leaf. So these studies are in progress, which tell us about um, endovascular treatment or open bypass treatment in a arterial lesion. So this is about EVT. In next video, we will discuss about open bypass surgery. Thank you.